So this is the greater Palatine nerve injection. On the palatal injections, you have the GP, the NP, which is the greater Palatine, nasopalatine, the only two maxillary injections which contact bone. I know that. The greater Palatine injections recommended when you need lingual soft tissue anesthesia, distal to the canines. And the nasopalatine injection is recommended when you need lingual soft tissue anesthesia from canine to canine. Pressure anesthesia utilizing a cotton tip applicator in the area of the needle is what is recommended. So we always use pressure anesthesia, and what they mean by that is the pressure from a cotton tip applicator. It's also really important to remember that no teeth are anesthetized during the greater Palatine or the nasopalatine. No pulps. No teeth are anesthetized on those. It's only soft tissue that is anesthetized on both of these palatal injections. So it's the lingual gingival tissue of the maxillary premolars and molars and the posterior hard palate in one quadrant. So you would need to give a right greater Palatine and a left greater Palatine. So the two main things I want you to take away from these pictures is, number one, you can do this as a clinician from the side of the face. And you can usually have the patient's head tipped way far back so you can see up on the palate of the greater Palatine. So the second picture shows that you are, with one hand, you have pressure applied with a cotton tip applicator. And so usually you find the foramen, which you can kind of find with the cotton tip applicator. You palpate the area, and then you can definitely feel a little spot that is, it goes down. It's like ulcerated. It kind of goes down a little bit, and that's the actual foramen. And so we don't put the needle into that foramen. We put the cotton tip applicator over the foramen, and then we go ahead and inject beside the cotton tip applicator, as close to it as we can get without going through it with our needle. So this, I think, maybe was for the picture purposes. The difference is that we would have the needle more on top of that cotton tip applicator, because since the patient is laying down, gravity is going to pull that anesthetic downward, and we want it to go into that foramen. So we would position the needle just superior to the cotton tip applicator instead of to the side. So the first thing you do is find that little foramen, and then you apply steady pressure. And you need to apply it until you see this blanching right here of the tissue, the white. Now they talk about putting the needle in until you see it kind of bow a little bit like that. We don't really find that that's that necessary. This is showing the needle more at the top of the cotton tip applicator. However, it really should be a little closer to the cotton tip applicator. So the nerves anesthetized are going to be the greater Palatine. It's whatever the injection name is, or the nerves that you're trying to anesthetize. The area is the posterior portion of the hard palate. It's overlying soft tissues, and it goes forward or anteriorly as far as the first premolar, and then it goes all the way medially to the midline of the palate. So it just takes that in when you look at the picture, just make sure that gets an imprint in your brain. So why you would want to give this is if you are doing SRP and you need it for pain control, and they have super deep pockets on the palatal side, and they have like maybe they're 12s and there's quite a few of them and they're wide and big with tons of calculus, you're going to be back there a long time, you would need to give a palatal. So contraindications, of course, are going to be inflammation or infection. Or if you need to just get 1 or 2 teeth, you would not do an entire block of teeth like this. What they do for that is they have something called the palatal infiltrations, and we'll go over that when we go over, I think that's put actually in the mandibular section, and we'll go over it later anyway. So advantages, you need fewer needle penetrations. Disadvantages, there's no hemostasis except in the immediate area of injection. So it's not going to have a lot of bleeding control except right exactly where you are anesthetizing. Positive aspiration, less than 1%. This tissue on the palate is rubbery. So your needle is not going to glide like it did on the orange, or it will in the soft tissue and other places of the mouth. It is definitely going to, you have to put a little bit more pressure in this area. The area of insertion is the soft tissue just slightly before or anterior to the greater palatine foramen and the cotton tip applicator. So the greater palatine foramen and junction of the maxillary alveolar process and palatal bone, those would be your landmarks. Path of insertion, you advance the syringe from the opposite side of the mouth at a right angle. So if you come from the opposite side of the mouth with your barrel and of your syringe and your needle, and when you place that to penetrate the palate, you can place it almost straight on, which makes a 90-degree angle. And that's the angle that you need to do for the greater palatine. 90-degree angle, I'd know that, or a right angle. Bevel needs to be toward the palatal soft tissues. So you need to ask the patient to open wide, extend their neck, turn their head toward you. So when you're trying to palpate for the foramen, you are going to start with your cotton tip applicator around the maxillary first molar and palpate backwards, posteriorly, just a little bit at a time, and pressing that into the tissues with the swab, and then it's going to fall into a deep depression, and that's the palatal foramen. So the foramen is most frequently located distal to the second maxillary permanent molar, but it could be located anterior or posterior to its usual position. On 95% of the people, though, it is going to be just distal to the maxillary second molar. So you're going to prepare the tissue at the injection site, just 1 to 2 millimeters anterior to the greater palatine foramen. So after you put topical, not into the foramen, but where you're going to be penetrating the needle. So after 2 minutes, then you can move it posteriorly so that it is then right over the greater palatine foramen. So you're going to apply considerable pressure at that area with the swab in the left hand, and you'll note ischemia or white blanching of the tissue at the injection site. So you're still applying pressure the whole way through the injection. So it's a minimum of 30 seconds. When you do this, right before you'll be applying pressure for 30 seconds, and then you'll go ahead and approach from the opposite side at a right angle. So place the bevel, not the point of the needle, gently against the previously blanched soft tissue, and it needs to be very well stabilized because it is rubbery and it's going to be a little bit of a pressure pushing that into the palatal tissue. So that's what's going to bow the bevel slightly. So deposit a small amount of anesthetic to the outside of the mucous membrane until a droplet forms. And that's really hard to do so that you don't do too much. So when you get more seasoned, you'll be doing that. And you're going to straighten the needle and let the bevel penetrate the mucosa. So as you are, it's a little harder also to deposit. You're used to that thumb ring going way too easy, sometimes almost down. And when you push down on the thumb ring, it's not going to give as much because on the opposite end, that anesthetic is trying to go into really dense, thick tissue. But the ischemia, the white part, will begin to spread, and you're going to continue to apply the pressure. You're going to slowly advance. It's usually about 5 millimeters. There we go again with 5. So 5 millimeters of the needle that goes in. You can continue to deposit small volumes of anesthetic as you're going in. That's kind of hard to do. So you're going to aspirate still in 2 planes. And if it's negative, over 30 seconds, minimum, not more than 1/4 to 1/3 of a cartridge. You can give up to 1/3 of a cartridge on this particular injection. So withdraw and make your needle safe. Wait 2 minutes, 2 to 3 on. There are hygienists who, this is called pressure anesthesia, and they don't put topical on. They will go ahead and use the pressure to take away the pain. That's supposed to dull the pain of it as you're pushing that, making that cotton tip applicator go into the tissue. We do both. So we're going to apply topical and we're still going to use pressure. So they're going to start to feel numb at the posterior portion of their palate. And a safety feature is that you do contact bone with both of the palatal injections, and you do not enter the foramen, and there's like a 95% success rate with this. Inadequate anesthesia could be a complication, and it's very rare. They have very few cases of this. Maybe you injected too far anterior to the greater palatine foramen. Maybe there's crossover innervation from the nasal nerve of the maxillary first premolar. After reinsertion, you're going to direct the needle more posteriorly. So you would want to go back in if they were not numb at all. And you can go ahead and administer the nasopalatine block if there's crossover innervation around the premolars. One complication is that the patient can get this gagging feeling because you're back by the, you're at the hard palate, but it's like super close to the soft palate, which is what gives everybody that gagging. So when the soft palate accidentally, if it becomes anesthetized, maybe you put the needle too far back and you're back by the lesser palatine foramens, it's going to numb that, and it's going to a lot of times make them start to gag, which you will then set them up and reassure them. And the directions say to have the patient avoid swallowing until the anesthesia wears off, which could be 2 to 3 hours. So I'm not sure how you would prevent someone from swallowing for that long, but there it is. Some complications will be if the person's really high vaulted palate or large midline tori. Palatal tori could be an issue. Ischemia and necrosis of the soft tissues, if you use like a 4% solution, highly concentrated vaso solutions are used for hemostasis. Norepinephrine should never be used. It definitely causes necrosis or death of the tissue. And hematomas are possible, but very rare. So that's the greater palatine.